The topic that we discussed to be of relevance for this audience was the use of what is the current status for the use of IV thrombolytics, and also the potential the trials that are ongoing, and also as well as the potential new application drugs on the fight against acute stroke that we should know about it. And the most important part, I think this sentence summarizes a lot the burden of stroke. You can appreciate that the most efficient treatment is extremely important. We have some determined treatment and standards of care that now, when we have new therapies being developed, we have to compare against or see how that fits on the workflow of this stroke treatment. But the most important part is to understand that our goal with those trials and bringing new technology and new techniques is that we need to keep our eye on the ball, seeing that we need to do this most efficiently to recognize the stroke and reopen the blood vessel and reestablish the blood flow as soon as possible in the most efficient way. So with that in mind, you have to see that there are a number of stroke trials in different spectrum, from the beginning, the prevention of stroke, the ways how patients get to the best medical center, and then you have the new intervention with drugs, new indications for mechanical thrombectomy, and perhaps also influence on the recovery, the rehabilitation of this patient. So in this whole spectrum, we have new developments, and maybe it's not going to be one in particular that will do everything, but a combination of the discoveries in the different levels of of the patient pathway. And for that, we have trials on the way in almost every sector. We're going to focus on the drugs and how thrombolytics are being used today. So we'll describe the current status of IV thrombolysis and mechanical thrombectomy, how that interacts together, as well as the ongoing future research on that issue. Now, the guidelines from the American Heart Association, this is publishing in 2019. In this publication by Power et al., you have the recommendation that IV TPA or intravenous TPA or Alteplase is still a recommendation 1A in terms of the first 3 hours of presentation with a acute stroke. So it's a very strong recommendation and a standard of care to date, still the use of VTPA on the first 3 hours of presentation. Now, we can extend that to 4 hours and a half in certain situations, but a VTPA still is today recommended in class 1A. Now, the new kid on the block, the new hope is perhaps the use in the growing evidence, but at this point, still a 2B evidence, is the use of TENECTAPLASE. And this is in a dose of 0.25 milligrams per kilogram. And this is certainly right now a possibility, but it's not as strong evidence as TPA. But certainly we'll discuss now some of the trials that are ongoing and some of the evidence we have today to get us to 2B evidence level. And I will call TNK for TENECTAPLASE so that we can have that understanding of what we're talking about. So TENECTAPLASE, why is that exciting? There's a lot of promise that this could be available for the current population that's treated with TPA, but also for future groups of patients, such as delayed presentation up to 24 hours, for example. So that is something that potentially could be expanding the use of intravenous medications. TENECTAPLASE has a longer half-life and has its potential to be used only with a single intravenous bolus administration, no infusion. So it's extremely efficient because you give one dose and the patient can potentially doesn't need to have a continuous drip after that, and making it certainly much faster if the patient will be in a drip and ship situation, or the time it takes for that patient to finalize the treatment is much faster. So it's a more fibrin-specific, less systemic depletion of the circulating fibrinogen. And so some of the trials, and this is the challenge right now, is NOR test. It was a trial that showed that the TENECTAPLASE TNK was not superior to TPA, but it has a similar safety profile. So in this particular trial, this is showing a little bit of the safety profile of the drug, but they couldn't yet quite make into, for mild strokes, into a necessarily completely positive trial. The other trial that is important to mention is the Extend IA TNK. And in this trial, as well as some of the reviews, I'm going to demonstrate to you what's available today. And in this graph, you can appreciate some of the trials that have been done from 2005 all the way to 2018, demonstrating this is, of course, a type of trial. The doses have been a huge variation on the types of doses to try to fine-tune what would be helpful for TNK. And then the comparison here showing that if there was a comparison to TPA or not, and not every evidence we have. That's why the evidence is not as strong as we have for TPA, but demonstrating that we're moving into a pathway to identify which patients benefit, what is the dose that be the best for this. And this is a meta-analysis by Jeff Saver that compared 5 of the randomized trials comparing TNK versus TPA, and basically the conclusion is that there is no inferiority. So that is really here demonstrating some of the trials had actually, you can see down here, endovascular was not exactly tested very much, is mostly being medical trials, but there is now a trend towards actually bringing that to a combination with mechanical thrombectomy. And that is certainly something that we are paying attention and participating in that process. Here you can see that some evidence that even though it was not statistically significant, that the patients had less disability on the group of TNK. So more patients at 3 months had the ranking scores were lower or better, outcomes with the use of TNK. This is definitely showing a trend of safety and perhaps some improvement, but was not statistically significant on this meta-analysis. So what are some of the trials that are going on from the drug standpoint? Timeless is a trial that we are participating. It's a TENECTAPLASE in stroke patients between 4.5 hours and 24 hours. So intravenous therapy, extended window, and this is actually randomizing as we speak now. So I can share with you much more. So just that this is being tested. And these patients are, being offered the standard treatment versus TENECTAPLASE for the treatment of in 4.5 to 24 hours of presentation. The other one is now two different trials. One is called Mr. Clean MAD. This is a trial from the Netherlands group that is looking into the use of IV aspirin and or heparin with the TPA. So you have now the moment the patient is getting the thrombectomy, they are refusing either aspirin or heparin, or patients with thrombolytics. So this will be looking into the concomitant use during thrombectomy of aspirin, heparin, or no adjunctive medication. The other trial is called MOST, and this one is part of a stroke net. It's NIH-funded that's trial that likely will finish in 2024. And this is now looking to multiple groups of patients with IVTPA plus placebo or IVTPA and the use of a direct thrombin inhibitor like argatroban, or IVTPA and a 2B3A inhibitor. We just talked about the use of integralin. So this is now a trial that will explore the use of different strategies to deal with thrombolysis in patients having acute stroke. Now, I think this is really good, and we're going to be talking to Dr. Fiedler from Germany in some of the sessions that you have today. And his recent publication, this just came this year, was about the impact of IVTPA and on the protection against distal embolization during mechanical thrombectomy. So the question here was, if you did an MRI, a high definition MRI, in patients that had a thrombectomy and received TPA versus the ones that did not receive TPA, just had direct thrombectomy. And their conclusion was that the group that received intravenous TPA did not have a improvement on less distal embolization. This is subangiographic distal embolization. So it's detected only by MRI, not seen. So you had a recanalization, and in this case, TK2B 50 or better. And you also have to have, so angiographically looks a very good recanalization. Then they compare on MRIs if there was a difference on the number of distal strokes, and that was not the case. So there was no evidence on this study of any better outcomes from the standpoint of distal embolization when using TPA versus direct to the angiography, no TPA used. So that brings us to this other paradigm, which is, how about if you have a hospital that can offer thrombectomy, and do you need to give TPA to those patients that arrive to the hospital early, within those first 3 hours, that it is a standard of care to use TPA? So Direct MT was published, it's a Chinese effort that was published in New England Journal of Medicine in 2020. And this was one trial that showed that there was no inferiority of taking patients directly to the cath lab for thrombectomy when they present to a center that can do that. So, of course, this was a very debatable result, because the natural impulse, even today, if you come to a comprehensive stroke center, which is able to do thrombectomy, most of us are using the TPA within those first 3 up to 4.5 hours. That is the standard of care for intravenous therapy. But this trial then was the first challenge to that. Now, this was a positive trial. Now we have a trial that was recently published, Mr. Clean No IV, and this is a trial also looking on the use of intravenous TPA or no IV TPA and thrombectomy. These patients were all within that they were TPA eligible within the first 4.5 hours and an LVO, of course. And in this trial, it did not show any superiority or nor inferiority of direct endovascular treatment over the combination of TPA and endovascular. So in this case, I did not show on Mr. Clean No IV a superiority of the direct to the angio suite approach, no use of TPA. So that was definitely important information to understand that what we're doing today is this was a randomized trial, also 539 patients that had LVO on the anterior circulation. And in this case, there was actually the functional outcomes in about the first 7 days, and the median NIH stroke score in these cases favored actually the IV TPA group before the mechanical thrombectomy. So the mortality rate on this trial, though, was higher in patients who did not receive the TPA. And this is quite interesting. Also, the number of intracranial hemorrhage, there was no difference between direct or in combination. So this is also very important, symptomatic and asymptomatic intracranial hemorrhage. There was no significant difference on the two groups. Now, there are other studies, DEVT and SKIP. These are trials that were also, it's part of this SHRINE subgroup analysis that is suggested no IV may be better, but it still could not be strong enough to show a superiority of going directly to the angio suite without the TPA. And in these studies, they suggested maybe in 3 groups, patients that have atrial fibrillation or have intracranial internal carotid artery occlusion or have a onset of stroke to puncture that is more than 3 hours, that they could benefit to go directly to the angio suite. But of course, this is not this is a trend. It's not necessarily a die-hard recommendation yet, but it's showing that there may be subgroups of patients that if you go to the right hospital with one of these conditions, you may benefit going directly to the angio suite versus receiving TPA and then going to the angio suite. Now, SWIFT Direct is a European trial looking at the similar issue. In this case, these are IVTPA eligible patients with large vessel occlusion and aspect score more than 4. And this trial just finished, and we don't have the final results on that. I think some of the speakers in our meeting are part of this study, so they may be able to comment. I think Mark Rebo will be coming later on today, and but we're waiting for the results of the trial. He just finished like a few months ago. Now, there's another aspect that I think is really interesting, which is when you look at the pre-hospital screening, you know, the different models of stroke workflow, drip and ship, mothership, and then direct to angio suite. This direct to angio suite is a new trend, and it's getting better and better as our technology of imaging in the angiography suite gets better. And we're talking here about you have a patient that goes from the field, from the stroke site, directly into the angiography suite, and the first CAT scan is done in the angiography suite. And this is only possible because the angiography suites are much better equipped nowadays. The name of this study is called We Trust, and this study we likely will have one done. This is funded mainly by Philips, but I'm quite sure we're looking, and Tudor Joven has a proposal potentially to have a similar trial done with Siemens but likely in the end, you will see, a combination of sites that have a capability to obtain imaging in the angio suite, and this is using flat panel technology to detect if the patient has a hemorrhage or not, and then also identify if there is a large vessel occlusion, and also identify if the stroke volume is significant or not, or maybe one can say that you do the screening in the angiography suite first, not stopping in the emergency room, not you go directly to the angiography suite. So it's a multi-center randomized trial that will take directly to the angio suite. And this is very challenging because, you have, when you want to enroll 500 patients, 16 different sites globally, there are some challenges because if you take every patient that comes with a stroke code to the angio suite, you'll be very overwhelmed and perhaps not very productive for the angiography suite. So how do you develop the screening of those patients before? And it looks that the patients that have aspect score that are certainly less than 5 plus a combination of an LVO, you really may be able to have I think I should say the aspect score more than 5 and an LVO. This population likely will be a good group of patients to screen, meaning they have the cone beam CT is able to detect likely aspect score that are less than 5, and with the CTA capability on the flat panel technology, you should be able to detect LVO also. But I wanted to emphasize one aspect of this on the screening, that patients that have aspects more than 5 and that have basically the chance to have they're presented within 6 hours, their chance is higher than 90% that they probably would still benefit from therapy. So there is a benefit to bring those patients directly to the angio suite, because the longer APAS you're going after here, the fast progressors. So you're trying to save a significant number of patients that are progressing so fast that by doing the scans, you probably were not being able to capture them or save them in time. So I think this is very important that if you're presenting with a relatively early presentation and you have a aspects that is more than 5, you probably have a quick window to save these patients that are progressing very fast in their stroke. Another important point is that I wanted to share with you is that this is still something that is ongoing, and it's not something that we have yet any data. The trial is about to start, hopefully within towards the end of the year this year. Thank you so much.